Hi guys, good evening. Am I visible and audible to you guys? I will be looking at your live chat, so just let me know if the audio visual is all good. There is no lag that we face quite often, and then I shall begin talking about the top 25 images of MSK radiology. So we've done neuro, we've done thorax, and we've done gynae obs as well as GU. So now we are on to musculoskeletal radiology, which will involve a lot of overlap with orthopedic images that you see. So I mainly want to discuss bone tumors, which is a favorite for your exams, which is quite ironical because exams are not happening, but still we would continue to prepare for them because they are postponed, they are not cancelled, so they're going to happen eventually, and the best thing that we can do is make the best of this time and utilize it to the maximum advantage that it can yield us, right? So that is what we're going to be doing, and we'll continue to study through all of these special classes that we always have. Before that, just let me know if audio visual is good, guys. If you can just tell me. Yeah, perfect. All right, so I'm getting your comments. उसमें भी थोड़ा थोड़ा lag रहता है. All right, perfect. So my name is Zainab Bora, and I have done my MBBS and MD in radiology from AIIMS New Delhi. And tonight we have a special class at 11 o'clock just to address this issue of what do we do next, because our exams have again been postponed. So we have an informal session and then we have a formal session at 11 o'clock. जब we'll discuss कि क्या करना है, all right, what do we want to do next for the next 30 days, because that's the timeline that we have, that it's at least been postponed for 30 days. So let's keep that in mind and see how we can best strategize and make the best use of this time. All right, I don't want you to while away your time, because this is what you asked for, right? Isn't it? This is when the June date came, when it was announced that it's on 16th of June, everybody had just one thought, right, that agar July mein hota to it would have been perfect. So that is what we've gotten. So now you've gotten what you asked for, so we have to make sure that now you give it your best shot. Right now time is not an issue anymore. Duties are again not an issue, so all of these things now have been taken care of. So you have to take this in your stride. I know it's easier said than done. It must be a very difficult time for all of you, which it has been for a very long time. I mean, it's just an understatement even saying these words out कि ये difficult time चल रहा है. It's definitely an understatement, and it's, you know, no, 10 p.m. wala is also there, but I can't say it out here, no. So, but 11 p.m. wala is also there on special class on Unacademy. Okay, so yeah, in fact, like, not just you guys. I mean, we've been through, like, not I can speak for myself. Like, I've been through this with you guys since December, November, if not more. And it's equally frustrating for me. So I can't even imagine the plight of you guys. If it's so frustrating for me, all of these changes, I can't even imagine कि बाकी सबका क्या हाल है. But then what to do, you know? Unusual times call for unusual circumstances, and that is what is happening, and we live with it. We take it one day at a time. We take baby steps, right? All my favorite words that you guys have. So we do it one day at a time, and that is how we'll be planning our strategy today. Okay, so anything that happens, we just try and make the best of it, right? That is the only thing we can do at this point. Okay, so after this enough wisdom, which you shall hear more of again at 11 o'clock for the nth time. Let's begin with academics. So plus subscription, you guys know about it. So now is again a very good time to get use of this, because you have time and you can use a few extra resources if you guys want. And iconic subscription, I definitely agree that mental health is taking a big toll on everybody, and it's not just the exams, right? Just the kind of times that we are living in, it's very, very tough. And all of these uncertainty about an exam, which is again a very high stake exam, it's something which is very, very difficult. I just, you know, can't empathize enough. But then all of you are in the same boat, isn't it? Everybody is in the same boat. If not, a lot of you guys are in the same boat, and we can just be together and help each other out through it. That's the only thing we can do to keep our mental, physical health in check. That is the only thing we can do, right? So we'll do that, and to help you in that, Unacademy has come up with this rapid review of emergencies, and now you guys have to check it out, because the surprise which we are gonna tell you on that day is gonna be even more relevant now that the exams have been postponed. That is one hint I can give you about the surprise that you guys keep asking me, है ना, कि कुछ तो अच्छा आपको अब और it becomes more relevant now. All right, so that is one tiny hint that I am dropping. And these are the various subscription packages which you guys know, 3+1 and 12+2 that you can avail. And these are the batch courses which are on at this moment. FMG exams, again, elephant in the room, FMG exams haven't been postponed as of now. So you guys have to prepare as if they are gonna be conducted, and now for the remaining days our entire focus is gonna be on you, such that we do the most important images that we are doing. Apart from that, on Unacademy also I'll come up with a few special classes of the must do images. Alright, so that is what is there. And FMG grant test, you have a grant test just to appear for the final mock before your exams. Alright, Varsha, so all your first aid questions, all your any questions now that you have, 11 p.m, just bring them to the special class on Unacademy, and I will be very happy to take them up, because again, there's no academic agenda for 11 p.m. class, so we can take up any queries that you have about what resources to use and all that. Okay, and you can use my code, which is ZVORA or ZVORA Live, in order to take it. Okay, so shall we begin with the first image? So first we want to do bone tumors, which is something which is a short question which always comes. So FMG students also who are attending this class, this is something which is utmost important कि ये सवाल तो आएगा ही. So when we talk about bone tumors, always remember two things are going to help you a lot: age of the patient, and second point would be where is the tumor located. Alright, is the tumor located in the epiphysis, metaphysis, diaphysis? This becomes the most important localizer that you want to look for. Apart from that, you also look at whether it's central or it's eccentric, but always the most important factor is going to be whether it's epiphyseal, metaphyseal, diaphyseal. Alright, so now what we are alright, so what we are seeing here is that this is the epiphysis, right? So this is the epiphysis and this is the metaphysis. And one more hint, even though the age hasn't been given, do you guys notice here how the growth plate hasn't fused, right? The epiphysis hasn't fused, the growth plate is still visualized. So this tells you that likely it is a person who is a child. So tell me guys, if I have to do an age estimation of this person, can you tell me what would be the likely age? You see that the knee is not ready. Do you remember Eshaki wrist? Those of you who are older students here, Eshaki wrist, knee falls somewhere in between 16 and 19, right? So somewhere around 17 to 18 years, the knee has to be completely ready. So can I say that this bachu here is less than 17 to 18 years? Because everything else has appeared, it's just the epiphysis which has not fused. So can I say, as Karishma has correctly said, that this person is less than 17 to 18 years, right? So in the second decade of life. Perfect. So now, in this 17 to 18-year-old, when I see an epiphyseal well-defined lesion, my first DD, as all of you are correctly saying, is gonna be chondroblastoma, right? So how do we remember? ECG, right? We remember ECG. So two epiphyseal lesions. One is chondroblastoma, and when you see a tumor like this, wherein again it's in the epiphysis, but in a skeletally mature patient, in a patient who's 30 to 40 years of age, wherein there's a large lesion going from epi to meta with a soap bubble kind of appearance. This is your prototype question that you need to know, which you can't afford to get wrong. Giant cell tumor. So there's a giant cell tumor wherein you find this soap bubble kind of trabeculations because it is filled with blood, right? It is filled with blood, it is filled with giant cells, and that is why when I do an MRI for this patient, I'm going to find that there are various levels. Remember, any hemorrhagic lesion, alright, any lesion which has bleeding which might occur in it, on MRI, what do I find? That the typical phrase is blood fluid or fluid levels, alright. There'll be these horizontal levels that we find. GCT is one of them. Can you tell me one metaphyseal lesion जिसके नाम में ही something to do with blood comes? What is that? That is aneurysmal bone cyst, right? So aneurysmal bone cyst also will have fluid levels. Can you tell me something, a variant of osteosarcoma, which again is very vascular? The name itself gives you a hint. It is telangiectatic OS, right? So the telangiectatic variant of osteosarcoma. वैसे तो osteosarcoma is a bone forming tumor, right? It's a bone forming osteogenic tumor, but in this variant telangiectatic OS, you have a lot of vascularity which can occur. Alright, so these are the common tumors which have fluid levels. And apart from that, also remember when you have very vascular metastasis like clear cell RCC, like follicular thyroid CA, you will see these fluid levels. Alright, so this is something which is pretty important for INICT. Alright, but these two images very very important for those of you who are FMG aspirants. This is something which has been asked like crazy number of times. Okay, so please don't get GCT wrong, particularly when you find that it's at the distal end of radius. Alright, okay, now let's look at the next set of questions. What are we seeing here? When I tell you that there's a child who came to me with a swelling of the lower limb, with erythema, with fever, what are we seeing here? We are seeing that there is a diaphyseal lesion. And tell me, how is the destruction pattern? So there are three kinds of destruction that we know, right? Geographical, permeative, moth-eaten. Out of this, geographical sounds like a good type of destruction, right? That it is well defined. I can make out that ये normal bone रहेगा and ये tumor है, जैसे I did with my chondroblastoma. On the other hand, your aggressive tumors, they're gonna infiltrate the bone in such a way I would never know that this is the tumor and this is the normal bone. Look at this tumor in the image here. Do you see that the bone is destroyed, but I can't really make out where the bone is starting and where the tumor is starting. इसको क्या बोलते हैं? इसको बोलते हैं permeative destruction. And I also call it what? I can also call this something else. I can also call it with respect to zone of transition. I say that there is a wide zone of transition. It's infiltrating into the bone in a very wide way, such that both of these features, when you hear these descriptors, remember that these indicate that we are dealing with a bad aggressive tumor. Alright, on the other hand, how would I describe this? There's a geographical, well-defined lytic lesion with a narrow zone of transition that I can identify ये normal bone है, ये abnormal bone है. Here also, ये abnormal bone है, ये normal bone है. I can identify it with this margin which I can draw. So this tells me that it's likely to be a benign lesion. On the other hand, here I am worried for the child, right? That this is likely a malignant lesion. Now, as all of you were correctly telling, that here the periosteal reaction, aggressive periosteal reaction, like a sunburst reaction, right? So you're seeing a sunburst reaction here, which again tells you that it is a malignant lesion. All right, and based on the location, diaphyseal location, child with systemic features, with malignant features on imaging, this is Ewing sarcoma unless proven otherwise, right? So this is Ewing sarcoma unless proven otherwise. And remember, yes, as a lot of you are saying, there is this uplifting of periosteum also, which is Codman triangle. All right, so those of you who are confused कि Codman, sunburst, ये तो osteosarcoma में मिलता था. No, both of these just tell you that it is aggressive periosteal reaction, more often seen in OS, but it's not a rule, alright, at all. So you can see onion peel in osteosarcoma also. It just tells you that the periosteum is reacting in a bad way, alright. It's an aggressive tumor. Got it, everybody? Right. So this is our first diaphyseal lesion. So now let's talk about diaphyseal tumor. And today one of you had posted, I don't know if you are here on the group, कि ये vowel sticking together क्या है? So first of all, it is vowel sticking together, wherein you have various vowels which somehow correlate. Alright, so pathologies with different kinds of vowels will stick together. Alright, so one is Ewing sarcoma, then you have another tumor which is starting with a vowel, which is seen in a vowel माने A, E, I, O, U वाले vowels, okay, school वाले. And what you have here is another tibial tumor that you are seeing, which is again eccentric tumor which causes bowing of the bone. Yes, this is adamantinoma. This is adamantinoma, again a rare tumor, but again you see it starts with a vowel. And the third lesion that you see here is again starting with a vowel. It is osteoid osteoma. So three diaphyseal lesions you can remember, prototypes. Osteoid osteoma, typically you will have a variable age group, but nocturnal pain, nocturnal bone pain, that so Karishma, this is how that all the three vowels valley lesions will be diaphyseal. ECG for epiphyseal lesions, right? So chondroblastoma, giant cell tumor for epiphysis, whereas these three vowels for diaphysis. All right, that is how you can remember. So remember, in an osteoid osteoma, the nidus, the osteolytic nidus will release prostaglandins that causes nocturnal pain. And yes, we ablate this. So treatment of choice, CT guided radiofrequency ablation. Alright, everybody. So this is about the diaphyseal tumors. Looking at the next image, what are you seeing here? What are you seeing in this particular image? I tell you that there's a history of trauma. There's a history of trauma that this person had, and now he comes to you with this pain and swelling over the arm. When I look at the X-ray, I'm seeing this peripheral ossification, isn't it? I'm seeing that peripherally there is this ossification, but centrally it is pretty lucent. On the other hand, when I look at an ultrasound, this is an ultrasound image, look what's happening. We are within the muscles. Do you see this? This is the muscle. And one extra edge pointer for those of you who are INICT aspirants, this appearance, this fibrillary sort of appearance, this is very typical for the normal muscles, the normal tendons, that you will have this fibrillary appearance. Alright. Yes, Ghazal. So based on the site, which is the diaphysis, and the aggressive features and the child and the systemic features, we can combine all of these to say that it's a Ewing sarcoma. Yeah. Alright, and here, yes, you can have history of massage, you can have history of trauma. Alright, and you'll see that peripheral ossification or ultrasound pe you are seeing, what is this phenomenon called? जब बिल्कुल अंधेरा हो पीछे, this is posterior acoustic shadowing. So yes, as all of you have correctly told me, this is myositis ossificans, which is the tumor, which is the differential of myositis ossificans. So when I give you image A and image B, which is myositis ossificans out of these, it is again gonna be the peripheral ossification. So किसमें ज़्यादा dense periphery है और ज़्यादा dense center है? Do you see how here the center is very dense, whereas here the periphery is very dense? So this is gonna be myositis ossificans. How to remember? So remember, in myositis ossificans, right, you have an O. So just you have so many O's here. So because of this, you remember O, you remember peripheral ossification. On the other hand, here what are we seeing? Here we are seeing that there is this dense central sort of ossification, right? There's this central dense ossification, peripheral patchy ossification. And the most important thing, look where it's arising. Is it arising from within the bone? No. If you see, there is this cleft here. Do you see a cleft forming, a string forming? So this is the cleft or the string sign, which tells you that it's arising from the periphery of the bone, right? That it's arising from the parosteum. So this is a parosteal osteosarcoma, a surface osteosarcoma. Alright, remember, this is not your central prototype osteosarcoma. Alright, so this is something which is very important. Got it? Okay, what about this? What are we seeing here? When I show you this pelvic X-ray, I tell you it's a 70-year-old male who's presented with this swelling, very aggressive, rapidly developing swelling. What is the diagnosis? So look at the bone. First of all, long bone or flat bone? Flat bone is involved. Elderly patient. Look at the matrix. Do you see this sort of a stippled sort of matrix? So very good. When I use the term like stippled matrix, alright, or ring and arc calcification, लग रहा है छोटा छोटा ring and arc calcification. This is the prototype of chondrosarcoma. Occurs in flat bones, pelvis, scapula, clavicle, and it will have this ring and arc calcification in older patients. Apart from that, what else? Here also, if you see the hand bones are involved, first big clue, and look at the bony matrix. Can you see how there are these chotu dots which remind me of ring and arc, stippled sort of calcification? Yes, so this is what? This is again an enchondroma. So can I say anytime I see this sort of a matrix where it's stippled, where it's ring and arc, I can know that this is made up of cartilage. There is chondroid matrix. इसको बोलते हैं chondroid matrix, and anywhere I see this, I know that there is cartilage involved. Enchondroma, chondrosarcoma. And yes, as you are all perfectly saying, when you see multiple enchondromas without any soft tissue lesions, only we remember O for all yours. And when there are associated hemangiomas, we remember Maffucci syndrome. Perfect. Going ahead to this, again a spotter image that you don't need any history. You see this calcaneal lesion and there can be only one diagnosis. When you see कि calcaneum है और center में calcification है. You see this calcification in the center. This is your calcaneal intraosseous lipoma. So this is an intraosseous lipoma. Calcaneum is a very favored site. Alright, so remember this is intracalcaneal lipoma prototype image, spotter image. Alright, you can't afford to forget this. Going ahead to the next one. What are we seeing here? Again a very typical image. If I tell you, yes, if I tell you that there is history, there's history of neurofibromatosis 1 in this patient. And इन्हीं letters से आपका ये lesion भी बन जाएगा. What is this lesion? Very nice. So what we are seeing is in the tibia, Central or eccentric? Eccentric lesion. So more common in the tibia. Here you are seeing it in the femur. You will see that there is a lytic, again a soap bubble kind of lesion with a very sclerotic rim. You'll find that there's a white sclerotic rim here. This is NOF. So remember, NOF is associated with NF1, multiple NOFs. So N or F, non-ossifying fibromas. Alright. And one more syndrome, very nice Anisha. One more syndrome is called as Jaffe-Campanacci syndrome, which will also have multiple NOFs. In fact, Jaffe-Campanacci and NF1 are also related mutation-wise. Alright, so they have this relation, and the other relation they share is NOF. Alright, so remember, eccentric lesion in the femur, in the tibia with a sclerotic rim. And what do we do? How do we treat this, guys? Iska treatment kya hai? Extended curettage and grafting, excision, CT guided RFA. How do you want to treat this lesion? So remember, this is called a do not touch lesion. इसको बोलते हैं do not touch. इसका मतलब do not biopsy it, do not treat it. This is just gonna heal on its own. The diagnosis is radiological, and with time this is gonna just sclerose. पूरा sclerosis हो जाएगा, and this lesion will heal. Okay, so remember, do not do anything. इसलिए करिश्मा गॉट द आंसर कि अपने आप ये पूरा स्क्लीरोज क्या है, नॉन ऑसिफाइंग फाइब्रोमा है. सो स्लोली इट विल गेट ऑसिफाइड विथ टाइम. यू विल सी दैट ये बंदे का फिर से आप एक्सरे रिपीट करोगे, इट विल बी मोर वाइट, द रिम विल बिकम मोर वाइटर, देन विल बिकम इवन मोर वाइटर. सो इट स्लोली गेट ऑसिफाइड ऑन इट्स ओन. ऑलराइट, सो दिस इज non-ossifying fibroma. Slightly difficult image. Let me give you a clue. Let me show you two images of this patient. Now it might be easier. So here I'm seeing these sort of lesions, slightly difficult. But what are we seeing here? This is pretty clear. How are these bone tumors? Are they exophytic? Yes. So these are very nice. These are exostosis. These are osteochondromas which are growing away from the bone, right? They grow away from the joint. They grow away from the bone. And when you find so many of them, what is it? So this is hereditary multiple exostosis, also called as diaphyseal eclasis. So this is also referred to as diaphyseal eclasis. And the importance of exostosis is what? What is it? Osteochondroma. So osteo component, so you will see. What about the chondro component? So this is the cartilage cap which surrounds the lesion. And this cartilage cap, will I see it on the X-ray? No. For cartilage, what is the investigation of choice? Tell me from our thumb rules. It's going to be MR. Right, so on MRI we measure the cartilage cap thickness, and when it becomes more than 1.5 to 2 centimeters, that becomes an indication that it's becoming malignant. You have to do a extraperiosteal resection. That is the treatment of choice, extraperiosteal resection of the osteochondroma. Perfect, guys. Alright, and what is the importance of multiple of them? The risk of malignancy increases. अगर तो एक है solitary, only 1% risk of malignancy, but when you have familial, the risk becomes 5 to 20%. Alright, so this is about osteochondromas. Now very quickly, shall we do the names of all the osteochondritis, guys? Again, बहुत बार पूछते हैं, बहुत irritating नाम है सबके, so let's quickly do a quick revision of all the osteochondritis. What is it? A young male with pain at the tibial tuberosity. You are seeing that there is this irregularity at the tibial tuberosity. What is the diagnosis? So here, when you have this typical history of tenderness here at the tibial tuberosity, this is apophysitis. This is Osgood-Schlatter disease. So this is Osgood-Schlatter disease that you are seeing. Very, very important. Alright, very important prototype image that you need to remember. Next image. This thing is not moving. Hold on. Everything else is working, but wait, let me try. Alright, what is this? What is the second one that you are seeing here? What is the second image? Wherein the navicular bone is now completely avascular necrosis has happened. It becomes sclerotic, it has become flattened. So this is Osgood-Schlatter. And what do we call this? So remember one this thing, bathroom fittings company is Kohler's company. Yeah, so Kohler's, you remember, we walk on the bathroom using our foot. That is a very ajeeb mnemonic, but it helps you remember because there are a lot of things which start with K, right? So remember, this is Kohler's. Alright, so this is Kohler's disease, which is the avascular necrosis of navicular foot bone. On the other hand, when I show you this image, thank God, when I show you this image and you see sclerosis of lunate which is happening, right, Anisha? When we see sclerosis of scaphoid, what do we think? We think of AVN secondary to fracture, right? But when I see sclerosis of lunate, what is this? This is Keene box, right? This is Keene box. Hand में होता है anatomical stuff box. So remember, anatomical stuff box, Keene box. That is how you can remember. So this is not Keene box, but Keene box disease, which is AVN of lunate, right? And one more K, जो odd one out है. So when you have avascular necrosis of the vertebral body, एक और K, what is that? That is the Kummel's disease. That is the Kummel's disease. And yes, who wrote? Yeah, very good, Ritvik. So this is associated with negative ulnar variance, wherein the ulna is going to be distally placed. All right, it's going to be distally placed with respect to the radioulnar joint. So there's an association with Keene box disease. So तीनों याद हो गए, everybody? Kohler's, Keene box, odd one out, Kummel's disease, vertebral body. What is diverticulum? What is Commeral's diverticulum? If I ask you, एक और केस से अगर मुझे आपको confuse करना ही रहा, then tell me, what is Commeral's diverticulum? Commeral diverticulum मिलता है, remember? Tell me most common vascular anomaly of arch of aorta. There is one vessel which indents on indents on esophagus, causes dysphagia, posterior indentation. What is that artery? Aberrant right subclavian artery, dysphagia lusoria. Remember? So dysphagia lusoria, remember, उसके जो origin है, when the arch originates from there, it can become dilated to form this Commeral's diverticulum. Okay, so this is something which is important. Alright, why is this so hard? Because of the names, right? So this is what medicine people have done to us when you have all of these K's and L's which are all placed together. So we just try and recall them by making it harder so that we remember them by recalling it together. Okay, so anyways, what is this? So now we are on to the foot. What is this disease? When the calcaneal apophysis becomes sclerotic. When does this fuse, by the way? Jumping right into age estimation. When does this fuse? कंफर्म तो नहीं है बैड बॉय, कंफर्म तो अभी किसी ने किया नहीं है, बट जब तक कोई कंफर्म नहीं करता कि नहीं होगा तब तक कंफर्म्ड है कि होगा, राइट? सो व्हाट इज दिस? दैट दिस इज द कैल्केनियल एपोफाइसिस व्हिच इज called the Sever's disease. This is the Sever's disease wherein this apophysis and fuses. Very good, Ritik. It fuses at 14 years. So I can tell that this bacha here is less than 14 years. Alright? Okay. What about this? When the second metatarsal head, you are seeing that there is this sclerotic rim. What is this disease called? This disease is called as Freiberg's. इसको बोलते हैं Freiberg disease. Alright? And when you see this, what is this bone? सबसे पहले तो bone identify करो which is abnormal. So this is radius, this is ulna. बताओ radial head के पास, head का ही fancy name will be what? And what must be this bone? This must be the capitellum, right? So radial head, capitus, capitellum. So this is the capitellum bone, and when you have capitellum का osteonecrosis, what do we call it? Again, Priyanka Chopra, PC or CP, Connaught Place, sticking together. So C is capitellum and the disease is called what? Panner's disease. So this is the Panner's osteochondritis. And finally, something which is the most common, but we are doing it towards the end because it doesn't have a fancy name. What is this? This is something wherein one part of the osteochondral complex, means the bone and the cartilage become separated. What is this called? So this is referred to as osteochondritis dissecans, OCD. Obsessive compulsive disorder का दूसरा भाई osteochondritis dissecans, wherein a cartilage and the bone become separated, and the location is very, very typical. The location is where? Medial condyle or lateral femoral condyle. So this is the fibula. So this is the medial femoral condyle and lateral aspect of it. So lateral aspect of medial femoral condyle, it will get separated and it might be a loose body also. So पूरा का पूरा separation भी हो सकता है. One clinical sign that we see here, anybody can tell me? So there's something called as Wilson sign. Wilson sign में क्या मिलता है, कोई बताओ जरा? In Wilson sign, this child, because he has pain here, right? He has pain in the medial femoral condyle. Anytime the child will medially rotate. So जब medial rotation of knee होगा तब pain होगा, but not on lateral rotation. Alright, so pain on medial rotation, but not on lateral rotation because this gets impinged. The osteochondral complex gets impinged. There will be pain. All right, so yes, if there is any, not just symptomatic Ritvik, if there's any sign of separation, all right, if there's any sign of separation, we will have to operate this patient. All right, so tell me one more thing. What is the best investigation to see that this separation is happening? Is it going to be X-ray, CT, ultrasound, or MR? Bear in mind that we are talking about osteochondral complex. So I want to look at bone also, I want to look at cartilage also. So which is the ultimate investigation will tell me that bone marrow edema हो रहा है, cartilage में tear है, it's about to get separated? MR. Perfect. So MRI will be the best investigation to monitor these patients, and the moment we see that अरे ये तो निकल रहा है, it's getting separated, this becomes an indication for surgery. All right, so this is a very, very important condition. Okay guys, so shall we stop? So these were the images that I wanted to tell you. So we have done the most important bone tumors and the most important osteochondritis. So we have a jam-packed day ahead of us, night ahead of us. So I'll see you all at 10 o'clock for those of you who know where, and others I'll see you all at 11 o'clock on special class Unacademy about strategy कि हमें क्या करना है आगे और कैसे जिंदा रहना है for the next 30 days and how do we make the best of this time, right? So always that's gonna be the plan, that कैसे करें, how to best utilize the adversities that we have been faced with. Okay guys, so thank you so much, and I'll see you all tomorrow again 8 o'clock on YouTube itself for 30 more images from GI radiology. All right, okay guys.